So we move to this next session where we have the speaker is Dr. Jayanta Saha, and to chair the session, Professor is there, and Dr. Ranjan Sharma is here. Okay. Dr. Dajbishas, you let him start the session and Ranjan will join. You have the comments at the end of the session.
Okay, thank you. So am I audible and visible?
You are audible and visible very well.
Okay. So I welcome all the members of the audience, and I particularly congratulate the 4 S's of our cardiology fraternity: Shantanu, Soumitra, Subhro, and Saurav. So these 4 S's have organized a very fruitful and successful conference in the new normal days with a virtual thing. And we have got a very good speaker, none other than Dr. Jayanta Saha, whom I have been seeing for a long time since our SSKM days. He is a very energetic student, now a professor of cardiology in medical college. So we know the topic, pregnancy and heart disease. It's a problem for a big team. Big team means those dealing with the 2 patients, mother and the baby. And that a team effort is necessary. And often we cardiologists find with dismay that in our country, the disease of the pregnant mother is found at an advanced stage. So let us hear from Dr. Jayanta Saha. Jayanta, over to you.
Yes, thank you, sir. Respected Chairperson, sir, and my friends, it's a pleasure for me to join this program once more this year. Thanks to Professor Guho for this opportunity. My today's topic is pregnancy and heart disease, the conditions to be worried about. Next slide. Now, 1 to 4% of the pregnancies are complicated by heart disease, and mothers who are class 3, class 4 symptomatic, their mortality may reach up to 7%. The offspring complications occur in 18 to 30% of the patients, and the fetal mortality may reach even 1 to 4%. Next slide. Next slide. Now the cardiovascular diseases, it may be either pre-existing or developed during pregnancy. Next slide. Now the question is why pregnancy affects a diseased heart. The plasma volume increases by 40% by 24 weeks. There is increased heart rate by 20 to 32 weeks. Taken together, the cardiac output may increase by 30 to 50%. This a diseased heart may not tolerate always. Now the cardiac size may increase by 30% and the systolic function may decrease in the 3rd trimester. And as we all know that hypercoagulable state is pregnancy, so there are chances of venous thromboembolism. There is a decrease in the SVR and PVR as well. Now during labor, there is uterine contraction that adds to about 500 ml of blood. Moreover, there may be increased venous return after decompression of effect of the gravity uterus is gone after delivery. So there may be a rise in the systolic and diastolic blood pressure as well. So we need to have a pre-pregnancy counseling of the mother with a heart team approach, that is a pregnancy heart team approach, so that we can find out the high-risk pregnancies, the contraindicated ones, and as well as we can plan a high-risk pregnancy. Next slide. So what are the tools to predict a high-risk pregnancy? Let us find out the mothers who have a class 3, class 4 symptoms, ejection fraction less than 40%, severe left-sided obstruction, pulmonary arterial hypertension, cyanotic heart disease, mechanical prosthesis, and smoking. These are risk predictors for the mother as well as for the fetus. Now that is a patient-specific approach, but the more application is with the modified WHO classification, which says that the class 3 and class 4, class 3 is high risk and class 4 is a contraindication for pregnancy. So what are the class 4 ones? Next slide. So the red one, that is the severe pulmonary arterial hypertension, Eisenmenger, ejection fraction less than 30%, previous peripartum cardiomyopathy with LV dysfunction persisting, severe MS, symptomatic severe AS, severe coarctation. So these are all included in the class 4, and we should not go for pregnancy in these cases, and even abortion is required. Whereas class 3, where the event rate is 19 to 27%, the ejection fraction is between 30 to 45%, and mechanical valves are here in this group, where the tissue valves are in the class 2 to 3. Next. Now, the mothers who have congenital heart disease, the conotruncal abnormalities often go with genetic predisposition. There are congenital arrhythmias, cardiomyopathies, dysmorphic features of the mother, mental retardation, aortic disease, certain syndromes. These mothers their fetus should be screened with a nuchal fold thickness at 12 weeks, which can predict a congenital heart disease, as well as we should go for a fetal echo 19 to 22 weeks, and if required, a chorionic villus biopsy. Next. So what is the prevalence of the different diseases? Now, as we find that hypertension is the most frequent one, in the non-Western countries, still it is rheumatic heart disease, and in the Western countries, it is congenital heart disease. Next. Next slide. Now, the hypertensive disorders of the pregnancy, the definition is more than 140 by 90, severe when it is more than 160 by 110. Somebody who develops the hypertension below 20 weeks, it is called the pre-existing hypertension. But when it develops after 20 weeks, it is the gestational hypertension. And when it is combined with proteinuria, we call it as preeclampsia. Next. Now, somebody who is having gestational hypertension and preeclampsia, the cardiovascular mortality in this group of patients is higher, coronary artery disease is more, and heart failure risks are more. So we need to find out these mothers who are going to develop preeclampsia. So that is the age more than 40, BMI high, and CKD, SLE, diabetes, and history of hypertension in the previous pregnancy. These are the more prone mothers to develop preeclampsia. Next. So how do we treat? Somebody who is having 170 by 110, we need hospitalization. 150, 95, more than that needs medical management. But at 140 by 90, somebody who has got symptom, pre-existing hypertension with gestational hypertension or subclinical organ damage, we need to treat these patients as well. But what is the target BP? It is not very clear from the guidelines. The drugs we use are methyl-dopa, labetalol, and nifedipine. For emergency situations, we can go for injectable labetalol and hydralazine. And NTG can be used when there are lung congestion features due to heart failure. Aspirin may be used for prevention of preeclampsia. Next. Now, regarding valvular heart disease, mitral valve area, if it is less 1.5, lot of controversies. However, it may reach up to 50% in the second trimester with heart failure. We use selective beta blockers if required, diuretics. And regarding anticoagulation, even in sinus rhythm, somebody has got a large LA volume, congestive heart failure, or contrast echo in LA, they should be anticoagulated. And as we all know that BMD should be done in the second trimester, provided the patient is class 3, class 4 symptomatic, or pulmonary artery pressure is more than 50. Next. Regarding aortic stenosis, one thing should be very clear that asymptomatic severe AS with a normal LV function, they can proceed for pregnancy. But somebody who is having asymptomatic with severe with LV dysfunction, they should be counseled against pregnancy. Caesar is a better technique than vaginal delivery. That may be the preferred one. Next. Now, regarding lesions, a severe MR, there may be heart failure in 20 to 25% of the cases. So pre-pregnancy surgery is better planned than during surgery. For severe AR, we need to look at the aorta. And for severe TR, somebody who is symptomatic with RV dysfunction due to pulmonary arterial hypertension, these carry a much more risk compared to the others. Next. Now, a few diagnostic tools that we commonly use, one is ECG and echo. Certain changes occur in a normal pregnancy. Now, somebody may develop in the 3 and AVM waves and Q inversion may not be confused with, shouldn't be confused with AMI. LVH may be a normal finding. There may be a mild dilatation of the chambers, increase in the valve gradients due to increased cardiac output. Next. Now, regarding prosthetic valves, as we all know that the bioprosthetic valves, 79% event-free pregnancy, and that is due to the do not use anticoagulation in these patients. But anticoagulation required for the mechanical valves, only 58% event-free surgery pregnancy is there. Next. So in prosthetic valves, it's a choice between VK and low molecular heparin. VK, which is good for the mother's valve, while the low molecular heparin, which doesn't cross the placental barrier, is good for the child, rather the fetus. Rather, compared to that of the VK, there is the chances of valve thrombosis is higher with low molecular heparin. So the better we plan, in the first trimester, somebody who requires warfarin, the dose less than 5, we should continue it. If it is more than 5, the chances of fetopathy increases, so we should switch over to heparin. In the second and third trimester, up to 36 weeks, we should continue the patients on VKA, and that is a class 2A indication. After 36 weeks, we should switch over the patient to heparin, LMWH or unfractionated heparin. But before 36 hours before delivery, we should switch over the patient to unfractionated heparin, stop it 4 to 6 hours before, and restart 4 to 6 hours after delivery. Now, CS should be of choice for the patients who continue on VKA, otherwise there are chances of fetal ICH. Next. Now, regarding IHD, in the third trimester and postpartum period, the 3 to 4 times increased chances of AMI. Now, spontaneous coronary artery dissection is the most common one, maybe due to the changing hormonal milieu or changing shear stress. There is structural changes in the vessel wall that is responsible for the coronary dissections. Now, normal coronaries may be found due to spasm. There may be 18% IHD acute presentations of these patients. Now, regarding STEMI, primary PCI is of choice. Thrombolysis like TPA should be used only in bailout situations, though the advantage is that TPA doesn't cross the placental barrier, but there is good amount of subplacental hemorrhage in this group of patients. Regarding unstable angina, medical management should be of choice unless there is electrical instability or ongoing chest pain. Next. Regarding hypercholesteremia, only one thing is for sure, that statins are contraindicated. Next. Regarding cardiomyopathies, somebody peripartum cardiomyopathy, if it is less than 45% ejection fraction, LV may not be dilated. But somebody who has got less than 30% ejection fraction, LV IDD is more than 60, and RV is involved, they show very adverse outcomes. So another information regarding peripartum cardiomyopathy is that after pregnancy, if the ejection fraction doesn't improve by more than 50 to 55%, the next pregnancy shouldn't be allowed. Next. Acute heart failure management, it remains the same as that of the non-pregnant situation. Only one thing for sure, that in the antepartum period, after stabilization of the patients, we should, in the antepartum period, we should avoid ACE inhibitors and MRAs and ARNI. Next. Now, another two important diagnostic tools, one is X-ray and CT, which involves radiation, should be avoided in the first trimester, as we all know, and MRI without gadolinium can be tried for the patients for congenital heart disease and assessment of the aorta. Next. Now, radiation exposure, the target should be below 50 millicray, because above 100, the chances of fetal injury are more. But whatever investigations we use, like X-ray, CT, and even coronary angiography, the chances of exposure to the mother and the fetus is quite low. Next. Regarding pulmonary hypertension, the maximum risk is in the puerperial period. The maternal risk increases with severe pulmonary arterial hypertension, some with late hospitalization, and with general anesthesia. And the maternal mortality may reach up to 30%. And these patients should be in the clinic, should be followed up for the RV function on regular basis, look at the oxygen saturation, if required, go for anticoagulation, check the anticoagulation status, and look for any iron deficiency. A combination therapy of sildenafil and diuretics and even calcium channel blocker can be started very early, and bosentan, as we all know, is contraindicated because of the phytopathy. And meticulous fluid balance is very important, and we shouldn't dehydrate these patients, particularly who are in Eisenmenger. Because of the decrease in the afterload, there is an increase in the right to left shunt, and the maternal mortality may reach up to 50%. And modified WHO has kept it again in the class 4 situation, and termination should be considered. Next. Congenital heart disease, ASD, small VSD, PDA are well tolerated. Repair TOF, which often survives up to the adult age, here pulmonary regurgitation and RV failure is common. So we should keep an eye on those. And coarctation, which is unrepaired, with continuing hypertension, with aneurysm, close follow-up for hypertension control, and in aggressive situations, we can even think of covered stents. Next. Regarding transposition, where we go for an atrial switch rather than arterial switch, and in CCTGA, here the RV remains a systemic ventricle for a prolonged period, and chances of RV going into failure in this group of patients is high. So a systemic RV dysfunction with class 3, class 4 symptoms is a contraindication for pregnancy. And regarding Epstein, who are symptomatic, that is sinuses and heart failure is there, we should avoid pregnancy. Next. Aortic disease, Marfan syndrome and bicuspid aortic valve, 45 millimeter and 50 millimeter that we have been learning from our childhood, from our young age. But one thing is very important, that we should compare it with the body surface area, whose absolute value has not been there in the textbooks, but that is also very important. Otherwise, the chances of dissections are more in the last trimester and the post-trimester, postpartum period. Now, this for an MRI evaluation of the aorta before pregnancy, regular follow-up with echocardiography is very important of the aorta, and hypertension management and beta blockers throughout pregnancy, selective ones, are very important. For emergency surgery, we plan for type A dissections. Next. Aortoarteritis, no exacerbating effect of pregnancy on aortoarteritis progression. However, uncontrolled hypertension can lead to abortion, stillbirth, aortic dissection. So a meticulous control of the blood pressure is important, as well as a pregnancy should be planned in the remission rather than in the active phase. Next. The chances of pulmonary embolism is very high. Mortality may reach up to 3.5%. A clinical suspicion with a raised D dimer and compression USG of the proximal veins is very important.
1 minute left.
Okay. And VK is very important in the post-delivery situation up to 6 weeks. Next, 6 months. So this is my last slide. There is an acute conversion of SVT. We can choose adenosine for unstable patients. It is electrical cardioversion. We shouldn't be afraid of that. For prevention of SVT in WPW, flecainide and propofenone can be given. Without WPW, selective beta blockers, and selective beta blockers for AF and atrial tachycardia rate control. Last slide. Next. Next. So the key points are advancing maternal age with comorbidities have increased the maternal and fetal complications. To avoid, we should go for a cardio-obstetric team approach. Preconception counseling of the mother is important. Fetal echocardiography at 19 to 22 weeks. We should go for vaginal delivery except for aortic pathology, intractable heart failure, severe PH, and on oral anticoagulation. The mother should be counseled against pregnancy in modified WHO class 4. Peripartum cardiomyopathy with persisting DCM, we should discourage the subsequent pregnancies, and hypertension, methyl dopa, labetalol, and CCB are of choice. Thank you.
Thank you, Jayanta. You have covered the major areas in this very short time. Now, Dr. Guha, how much time do you have for the discussion?
Actually, there is not much time. If there is any question, you can...
Actually, I am picking up the question first rather than myself summarizing the issues.
Give some questions.
So this is a very important question and a very day-to-day problem for the cardiologists as well as the obstetricians. This is from Dr. Apurva Mukherjee. He is giving in the case scenario, 20-year-old girl detected to have mitral stenosis with less than 1.5 centimeter valve area. First time at the 14 weeks of pregnancy within 7 months of marriage. What should be the ideal approach? Can BMB be done? Yes or no?
So first thing is the patient is not very symptomatic during pregnancy. That is at least class 3 symptomatic. We should, better it is not to do any procedure. We should keep the patient on selective beta blockers if required, and if necessary, add some amount of diuretics. We should avoid any procedure. But if the patient goes on becoming symptomatic, despite these drugs, we can try to do balloon mitral valvuloplasty in this group of patients. Usually at 1.5 valve area, it is not very necessary. Just with beta blockers and diuretics, we can manage this patient.
But according to our experience, it is a bit unpredictable. Even then, if you have to contemplate for mitral valvuloplasty, which trimester would you prefer and what precaution would you take for radiation?
Sir, one thing is that it is the best to do in the second trimester, best to do even in the second 22 weeks because of certain parameters. And the second thing is that we from our teaching days, student days, we have been taught that put a shield below the mother's abdomen where the radiation source is there. Now, when I was going through the guidelines, they have discussed that putting this, how much does it help the mother is not very, they are not very sure. That is this particular written in the ESC guideline. They are saying that there is good amount of scattered radiation, and due to, and I have done a number of BMPs during pregnancy, what I have seen that this total time actually increases for this shield. To get the situation because of the pregnant mothers, the large abdomen and getting all these things, putting another shield, rather the total radiation dose may not actually decrease, rather it may remain the same. And putting a shield actually doesn't give a lot of protection.
Okay, thank you for your comment. But one thing, you also know as an experienced operator, moving up the broken barrow along the Mullin dilator or Mullin sheath, whatever you prefer, that becomes a bit difficult due to the bulky uterus. You have to be taking precaution, and the anatomy gets also a bit altered. Santanu, can we progress with further question or comment, or should we go on?
I think we don't have much time.
So we had a very good interaction, and we learned many things from Dr. Saha, particularly the usage of VKA. He has highlighted very well with the recent guidelines, because it is still in the mind of the people that warfarin embryopathy can happen at any time. So initial continuation of the drug, particularly if it is below 5 milligram, has been a very well addendum. But what we think in our country as well as in any other country, pre-pregnancy screening for heart disease is a must. And in the earlier months of pregnancy and also later months, pregnancy mimics can be there while clinically examining a patient. We all know, we often ask students, even MBBS, what are the mimics, confounding factors. Those will leave for later discussion. So thank you, everybody. Thanks the audience. Thanks Dr. Mukherjee for asking a beautiful question. And thanks Dr. Guha and his team.
Thank you very